Are you frozen? I can't hear anything. This is Wilma.
Hi, Wilma. How are you?
Okay.
Sorry, we're just waiting to get
Oh,
started. We're
okay. All right.
hopefully not frozen. Yes, but thank you for checking. Thanks for
Okay.
checking. Yeah. Yeah, for those who are already on, welcome. Thank you for joining us, and we'll get started in just a couple of minutes. Um, but to start off, if you want to introduce yourself in the chat and let us know what brought you to the forum, if you've been to these before, or if this is your first one, I do see lots of familiar names, which is wonderful. Welcome back. For those who this is their first forum, welcome. We'll get started in just a couple of minutes and I'll give you a little background on the forums and then we'll launch into the discussion for today. Okay, again, welcome everyone. We're going to get started in just a couple of minutes. If you've joined and want to introduce yourself in the chat, we always love to see who's joining us, whether it's those who have joined in the past or people joining for the first time. One thing for those who are joining for the first time, these are held monthly, and actually the registration that you have for today is the same login that you'll have and the same link that you'll have for any future forums. So now that you've got your registration link completed, you can join all the future forums as well. And we'll go through what the next one is for April. But for now, we'll again give it another couple of minutes and then we'll jump in. But I see lots of familiar faces and names, but also some new names as well. So welcome, and we'll get started shortly. I see some wisdom participants, which is wonderful. Welcome. Thanks for being part of the study. Wonderful. I see a good mix of first-time participants and those who have joined us in the past. So again, welcome. Right. Well, wonderful. Thanks everyone for joining. I think we'll go ahead and get started. We are still waiting on Dr. Esserman, Dr. Laura Esserman, who is the lead of the Wisdom Study. But in the meantime, we can go through some introductions and welcome people who maybe haven't joined before. Thank you, everyone, for being here. This is our monthly Wisdom Study Community Forum. Please do introduce yourself in the chat if you haven't already. I was just going through the chat and see lots of people who are joining for the first time, which is wonderful. And I mentioned earlier, but your registration link will get you in for all future forums. So we hope you'll join us in the future as well. I also see lots of wisdom participants, so wanted to take a minute and just say thank you so much for being part of the study and for being here and engaging in the discussion for today. So just to start off, format for today's discussion and for all of our community forums is we really do want to hear from our audience and we want to hear from you. So you can put your questions in the chat, raise your hand, we'll monitor the chat, and then we'll leave some time at the end to ask questions as well. If you're not speaking, we do ask that you mute yourself so that we can hear the speakers. And this is actually different. I didn't update this from the last one, but we do record these meetings and we make them available on our YouTube channel. So this one actually will be recorded. Last month was not. Apologies, that didn't get updated. And then at the end, there will be a short post-meeting survey for your feedback. Let's see. So the mission of these forums and the mission of these conversations really is to move together toward equity and better outcomes in breast cancer for everyone. We've been doing these forums for the last several years and doing them every single month with various topics. You can see sort of the breadth of the conversations and the topics here. We are always looking for new topics, and that's part of our feedback survey at the end, is to get your feedback on what you think would be of interest to hear about next. But for this month, we've got a great topic on menopause, hormone therapy, and breast cancer. And we are very lucky to have Dr. Corinne Menn, who is a menopause expert, medical advisor. She's a board certified OBGYN and a certified menopause certified practitioner. I will let her tell her story of her journey through the breast cancer space as well. It's a pretty interesting one, and I think there will be some great topics both in menopause, hormone replacement therapy, breast cancer risk, and also hormone replacement therapy after breast cancer as well. We have Dr. Laura Esserman, who's also joining us today to sort of be a discussant and to walk us through questions that I know she usually gets, but also, how we're thinking about breast cancer risk throughout the lifespan, and in particular around the perimenopause, menopause timeframe. So with that.
So thanks, Allison, so much. And, Corinne, we are certainly thrilled to have you here today. And I thought to make it a little bit more interesting for everyone, I'm going to start by asking you some questions and to try and get everyone else excited about doing this. So as everybody knows, one of the whole purpose of the wisdom study is to try to help us figure out who's at risk for what kind of breast cancer and how we can intercede and reduce people's risks in a timely way. But also, again, how we can learn from treatment, how we can take the insights from treatment to really accelerate the headroads that we can make about the inroads we can make about prevention. And, again, part of one of the things that we've learned, about, in medicine in general, that, it's just, there are no perfect answers. There are risks and balances. And it really depends a lot on your own situation, your own symptoms. There are no absolutes. We can't, although it does seem, I'm sure, to many survivors that the answer on whether or not you can have hormone replacement and if you had an ER-positive breast cancer is a flat no. We're going to talk to you about when and why perhaps we might want to adjust that. And there are some surprising things coming out, really, about things that might manage, your symptoms, that might also reduce your risks. And there are certain things that you can do that might increase your risks. There are situations that if your symptoms aren't that bad, maybe you don't want to increase your risk. But if they're really terrible or you can't get through your day, everything's a trade-off, right? So, and we also know that, many of our prevention ideas come from, how we treat endocrine positive breast cancers. And sometimes, the same side effects that people get during cancer treatment also happen during prevention. So we are on the hunt for things that improve people's quality of life. There are millions and millions of survivors and people who are really suffering from treatments and from sometimes lack of interventions. And so we want to approach this issue, thoughtfully with data. And sometimes there isn't always data to answer every question. And so you have to use some reasoning and insight for how to look at it. And of course, perhaps the most important question, one of the most important questions people ask, with they're worried about breast cancer, can I take hormone therapy? And we've got the extremes on one side who says everyone should be taking hormone therapy. And then we've got the people who are like, oh my God, let's not relive this again. We don't want to do that. So there's been a huge amount of controversy. So, and then also for the people who've had cancer, in what circumstances is it okay to think about symptom management and what are the things you can do? So those are just some of the topics we want to touch on today. Corinne, perhaps it would be interesting for us, for everyone to hear a little bit about why this topic is so interesting to you and sort of what your whole personal story is around on your own breast cancer risk and how you came to understand that you were indeed at increased risk for breast cancer.
Well, it's a long and interesting story. And thank you, first of all, so much for having me here. And, I learned about the Wisdom study at the Menopause Society annual scientific meeting a few years ago when it was highlighted by one of my colleagues, Dr. Lisa Larkin. And I was just so impressed by the study and so glad to have it to offer to my patients. So I'm so grateful for those of you who are participating. Spread the news. I think it really aligns with what I think is the most important thing in medicine is individualization. And as Dr. Laura Esterman, alluded to, like, Wisdom is looking, how do we individualize risk assessment and screening? So it's not a one size fits all, but that's how we should be approaching everything in medicine, from breast cancer treatments to menopause management and sexual health and everything in between. So, and that's what I really focus on in my practice. So thank you for having me. So
and of course, we have to generate the data, right?
Yeah, we need more data, ladies. We need more data. So this is super powerful. So yeah, my story is long and complicated, and I don't know if you want to spill all the beans at once. So how should we talk about this? I mean, I think I can start by saying I was a 28-year-old OBGYN, second-year resident. Never thought about breast cancer. We had no family history of breast or ovarian or any other, significant, red flag cancers. And I was newly married, and I felt a lump. And it was 2001, right after September 11th. I'll always remember that. And it was the first time I dismissed myself as a patient. And kind of gaslit myself, and my program director, who I loved, and my fellow OBGYN colleagues, we were all female. I let them feel the little lump, and they're like, "Oh, you're too young for breast cancer. We don't see breast cancer women." They say, "Oh, no, it's a cyst. Just watch it with a few menstrual cycles," which, of course, a palpable mass that's firm and mobile. You do not just watch for a couple menstrual cycles, but that's what I did, right? As an OBGYN, young doctor, I had a lot to learn. And it was a long time ago, the BRCA1 and 2 gene had just been, commercial testing and, patients getting access to this. This was a newish thing. So I waited, a number of months. And in the meantime, and this is for another discussion, my mom died suddenly of stage 4 ovarian cancer at only 54. That's a whole nother backstory. But at her funeral, I came home that day and I said, I think I need to get this lump checked out. But I still was not worried, strangely enough. And then right before Christmas in 2001, I was diagnosed with ERPR positive, HER2 negative, stage 2A breast cancer. And then I like to say that was when the re-education of Dr. Menn began, because through treatment, chemotherapy, I had fertility preservation, chemotherapy, years of adjuvant endocrine therapy, paused it for pregnancy, and then subsequently down the road had my ovaries taken out. I realized along the way that I was not well prepared to help myself with premature menopause, surgical menopause, medication-induced menopause, much less my average menopausal patient, because I was diagnosed in 2002. This was when the WHI study, which we'll get to later in the discussion about hormone therapy, created a lot of fear, misinformation, and mismessaging. It was a good study in many ways, but a lot of mismessaging. And that's when I was diagnosed with breast cancer. And our residency program, we had no menopause training. There was no discussion about menopause or how to treat it. There was no talk about, sexual side effects or genitourinary syndrome menopause, or none of that. Maybe a little bit on premature menopause, but really very little. And that exists to this day. There's a huge care vacuum, which we can talk
Corinne,
about.
I want to ask you a question. When you were first diagnosed, again, you're 28, mom died of ovarian cancer. BRCA1 was cloned in 1996, BRCA2 in 97.
Hmm.
So new, but still 4 or 5 years out. Were you offered genetic testing at that time?
I was, but it was kind of like, well, you can do it, but it's probably unlikely. And at the time, I was considering lumpectomy versus mastectomy. I was pushed into doing a unilateral mastectomy, despite my gut feeling that I really should have done them both. But it was so scary at the moment. And they're like, you might want to breastfeed. You might want to have a baby one day. Maybe you'll want that other breast. And so I reluctantly said, okay, we'll start with one. And I got like different opinions from all different top New York City breast surgeons. And so in my mind, I was like, well, I'm going to do both eventually. I had started with one, and down the road, I had the second one off. And so they're like, yeah, so, it doesn't really matter. It was a really uneducated attitude, frankly. And then once I got through chemo, I did ask to be tested. And surprisingly, I was tested negative. And that would have been in like 2002. And it never sat well with me. But at the time at that point, I had decided on having a bilateral mastectomy. And then the question of my ovaries was kind of put off for a later time, as I was like hoping to be able to get pregnant once I, was able to pause or finish my tamoxifen.
Yeah. And then later on, as of course, one of the things that's happened is that, genetic testing has evolved, and the number of mutations, this has actually come up on this forum, actually, where I know there were some women who said, well, wow, I don't have any family history, and my family's Black. I'm not Jewish, so there'd be no reason for me to get tested. But, there are 3 genes that are common in Jewish people. And the reason we knew about those first is because people went to the Tay-Sachs Bank to sort of look, and that's actually where those 3 genes came from. But there are over 500 different gene mutations now that we know about. So, around 2013, 2015, really, the panels really became, our ability to sequence and our ability to look more carefully has really come up. And there are now, even when we started Wisdom, there were 9 genes, and now there are 11 or 12. And one of the things that we found so surprising in Wisdom 1.0 is that of people who had mutations, 60% of people didn't have family history, or at least not that they knew about. And even if you were BRCA1, 40% didn't have a family history. So the very thing that we use to screen people to see whether they should get tested is not actually that helpful. What was it that got you to think about getting your testing redone, Corinne?
So it was interesting. So at the time, it was 2013 actually, and I was opening. I stepped away from full-time OBGYN. I stayed home with my little girls for a couple of years, and then I was ready to get back into the workforce, and I decided to open up my own office-based GYN practice. And so I was preparing for the opening of this practice, where I was going to focus on breast cancer survivorship health and menopause and perimenopause and sexual health. And I was doing my due diligence, and I was doing some continuing medical education. And I realized, oh, wow, like there's update testing, and there's something called the BART sequence, which is a large rearrangement of the BRCA1 and 2 gene that was not considered standard of care to be routinely tested or covered by insurance prior to 2013. And then there was also emerging other other genes beyond BRCA. So I called up my oncologist and I says, hey, and I'm not going to name names, but I'll just say the big famous cancer center in New York City didn't seem to think it was important to recall me. My breast oncologist, who was not at that famous cancer center, but at another famous cancer center in New York City, never thought that patients should be recalled and said, hey, you had genetic testing a long time ago. You're a high-risk patient. My OBGYN, my internist, nobody. But it was me because I had read that I probably should. When I asked for it, my oncologist, who I adore, he was like, well, it's probably, unlikely, Corinne, but, it's really rare for it to be in the bar. I'm like, well, it's really rare for 28-year-olds. Like, not many 28-year-olds get breast cancer, and their mothers die 6 weeks earlier of ovarian. And so sure enough, 4 weeks later, after I had my test done, I got the news. I'm a BRCA2 mutation carrier. And my mutation was in the BART sequence. And thank God I spoke up. Because subsequently I was able to inform my family members. My brother's positive. I've got a number of cousins and aunts and uncles who are positive. And after breast cancer, I was able to have a baby. I had one daughter biologically. I paused my tamoxifen, was able to get pregnant, and then went back on my tamoxifen to complete my treatment as recommended. And so she's going to be 21 this year. And then our second child, we decided to adopt. And so I had one biological child, and it was really important that, I knew that, because God forbid I didn't, right? And we went around assuming that we were negative. And last year we found out that my daughter is positive. We tested her at age 19. And she's really well prepared, and she's planning on early prophylactic surgery in the next 2 years. So because in our family, it happens very young, it seems. And so this is an example of just a patient being a squeaky wheel. I happen to be a doctor, but it never sat right with me. And it's very disappointing to me. I see a lot of breast cancer survivors who think that their family history is negative, or that they have a strong family history. They're not a breast cancer survivor, but they have a strong family history. And no one ever, or I'm sorry, they had a strong family history, and one of their relatives were tested negative. So they think that covers it. But just because your mom got tested years ago doesn't mean your family really is negative, and they might need update testing. But it's a problem because people don't get called back to be told. And most doctors don't even refer patients for genetic testing. That's why I really do love the wisdom study, because it's getting women access to that information.
So after you got your BRCA2 diagnosis, then you had your ovaries out.
My ovaries, I had already taken my ovaries out because I was with my childbearing, and I had been on Lupron and tamoxifen. Couldn't deal with that. Lupron was really hard for me. So I paused it. I was on tamoxifen alone for a few years. But I was always very nervous because my mom was so young when she had ovarian cancer, and I knew I wasn't going to have any more babies. So I was like, all right, let's take these ovaries out. And this was before I got my BRCA2. And it was that surgical menopause that really, really pushed me to get certified by the Menopause Society, because unlike the previous temporary menopauses from treatment, that surgical menopause hit me like a brick wall, and I really learned what it was like. And it's a lot more than hot flashes. And it really, really, really changed my quality of life, my body, my health in so many ways that I was like, I need to get more educated, because my residency didn't teach me this. So yeah, I had already had those ovaries out. So at that point, I had done all the things, but it was such important information for my family.
Yeah. So, all right. So let's talk about, this issue about hormone replacement. And so first we can talk about people who, who don't have, who have not had a diagnosis of cancer. Then we can talk about people who've had a diagnosis of cancer, because I think both, are very important. And there actually are many more options now than there used to be. So why, in your practice and sort of thinking about it, what I think that, it's interesting that I think it's very important that one of the things about the Women's Health Initiative is that it did show that some of the work that Ron Ross and 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 I'm forgetting his name. Anyway, another one of the big giants in the field had sort of been concerned about progesterone and its impact on increasing the risk of breast cancer. Not estrogen so much, but progesterone. So, and it's interesting that the regimens that were studied in the Women's Health Initiative are no longer used today. So in fact, we really do need to generate more data. And I think a lot of people aren't aware that the estrogen progesterone combination was stopped because of what we call the hazard rate 1.26, increased risk of breast cancer. Again, if your risk is super low, that may not be very meaningful. And if your risk is very high, you may want to think, twice about it or do something else, or depend on what your risks are. But, there are a number of agents that there are a number of things that we can do to improve symptoms of menopause. And one of the things that I think that I find that it's like, again, if someone goes through menopause early, you would normally have been exposed to hormones for a number of years. And so this idea that you can't have a low dose of replacement or using an estrogen patch, again, particularly if you've not kept your uterus. But again, I think people were more concerned about uterine cancer than they were about breast cancer. But in fact, the risks of dying of breast cancer are higher than the risks of dying of uterine cancer, which is not that common, but still can be found early. So how do you sort of balance all of those things for people?
So do you mind if I share, because I have some visuals I'd love to.
Fantastic. Why don't you go ahead, and that would be a good
And
time.
then we don't have to do them in order, but we can skip around so that they kind of work with like our questions. So let me just pull them up, and then you all can see the screen.
Yeah.
Okay. Tell me, can you see it being advanced?
Perfect.
Okay. So I'm just going to jump. This is just like the general kind of what Laura just said, is that, when I'm approaching someone with either premature menopause or menopause, and we can talk about why those two things are very, very different, we always have to remember, no matter all the noise you hear out there, some people say only, nutrition and diet and exercise and no hormones, or people say hormones are the cure-all for everything. The truth is always somewhere in the middle, right? We have a full toolkit as a holistic, individualized approach: lifestyle, nutrition, exercise. Hormone therapy has a strong role, vaginal hormones, and some great non-hormonal options, newer ones. And even the menopausal hormone therapy has really shifted, and we've got a lot of interesting options, which Dr. Esserman alluded to. I want to jump to we can come back to some of these interesting slides, but I just want to point out to everybody that the FDA has approved menopausal hormone therapy for 4 things: hot flashes, prevention of bone loss, premature hypoestrogenism. So if you have premature menopause before 40, and prevention and treatment of genitourinary syndrome of menopause. And that can also be addressed with local hormones. So I think it's important for people to remember, it's not just hot flashes and it's not just bone loss, but it's not just for the FDA approved indications. That's our main indications. But hormone therapy is helpful for a lot of, other things. And so we always want to balance risks and benefits of things. And we can come back to this, but I want to jump to the fear of breast cancer, because that's what we're here for today. And, the WHI study, for those of you on the call who don't know, was the biggest study of hormone therapy ever. It was done it was stopped short in 2002. And the message went out that estrogen caused breast cancer. That was the media message. And the study had 2 arms. And as Dr. Esserman was alluding to, if you had a uterus and we gave you estrogen alone, you could get uterine cancer. So you have to take a progestin or a progesterone with estrogen. And that was one arm of the study. So women who had a uterus. And then the other arm, women didn't have a uterus. They were just given estrogen alone. So these facts never made headlines. I don't know why. But the women who took estrogen alone had a 23% reduced risk of breast cancer at the 20-year follow-up of the study. and at a 40% decreased risk of death from breast cancer. And then we can talk about the combination in the other arm. So people are like, well, what about the other side of it? That's where all the risk was, right? There's a lot of critical reviews and opinions on this, but really we're going to skip this. I just want to show you this. And this is
I do want to say one thing about the combined hormone replacement was stopped because of the risk of breast cancer. And actually, I mean, we'll have to go back and look at it. There was also an increase in the risk of death of breast cancer. But of course, in the more modern therapy era, it's not necessarily clear. But the estrogen alone arm was stopped because of an increase in cardiovascular events. And one of the things that was actually learned by the study is that first pass effect through the liver is where you get that increased risk of blood clots. So if you use a patch, those risk of cardiac events is much lower, and if not, completely lower. So I think there are different ways in which you can think about how you use it, and that risk of uterine cancer, again, 92% is stage 1 uterine cancer that has a 95% survival rate. So it's, I think, very important to know those
women we don't see uterine cancer really in women who are taking modern menopausal hormone therapy when they're appropriately be given a progestin. And so,
but even without, you see it.
Even
without the kinds. I mean, again, if you had a high risk of breast cancer, you would probably avoid the progesterone. You'd take a patch, and you have a very small risk of uterine cancer. That's unlikely to kill you, also. So I think all of those things are important in thinking these through.
And I really like to show this to people, because I think that the problem out there is that we as doctors, as patients, as society, we do a really bad job at really explaining absolute risk versus relative risk. And we overestimate the risk for some reason of menopausal hormone therapy, and we totally underestimate the risks of lots of other things in life, right? Like alcohol use, or not being, having horrible sleep and stress and lots of other things. So we have to put things in context. So just to kind of show you, and this just take a minute to look at this. In this top graphic, that red dotted line, and this is looking at the women who initiated hormone therapy around the time of menopause, which is most women who won hormone therapy, right? Within the first 10 years. We're not talking about outliers, much older women, which that's a separate conversation. But women who took estrogen alone, the top thing here, anything below the red dotted line is considered rare, not statistically significant. There was a small increased risk of DVT and a pulmonary embolus. And this is what Dr. Esterman was referring to, is because women were being given oral estrogen. And we know oral estrogens, even oral birth control pills, can cause a slight risk of blood clots and a PE. But do we tell the millions of women on birth control pills that they can't take birth control because of that? No. Why do we say this for menopausal women who are suffering? And so these days we tend to recommend transdermal estrogen for people who are, at risk for those things. But look at the blue. These were all the benefits. Okay. Less stroke, less breast cancer, less all-cause mortality, less cancer deaths, less colorectal, less fractures, and less diabetes. Okay. And even the things that were risks barely reached the, rare red line mark. Okay. And then if you look at the combined, which the study was stopped early because of these risks of cardiovascular and breast, but it was this little yellow bump up here, this breast cancer, right? 6.0. So it didn't even meet this red line of being, more than rare risk. And we'll talk even what that risk was. You still maintained many benefits. And looking back at this data and looking at modern data, we now know that much of these risks, the stroke, PE, DVT, could be avoided if we used modern options, including a transdermal estrogen. And then to put it in this is an interesting graphic, and I think it helps with the relative risk versus absolute. And while some people will debate that even the increased risk with the synthetic progestin was not actually statistically significant, I'm going to take them at face value. The absolute risk of someone taking estrogen and progestin on their breast cancer risk went from 3 in 1,000 women to 3.8 in 1,000 women. So to put it in perspective, if you were in 1,000-person theater, like this is a theater chart, right? There'd be one extra woman sitting in that theater, actually less than one, a 0.8, for every 1,000 women taking that formulation, which we don't even prescribe much anymore. And she would have an increased risk of a diagnosis of breast cancer, but it did not at the 20-year mark translate to an increased risk of death of breast cancer. And it was based on that millions of women for the last 2 decades.
Well, so I'm
powerful.
gonna play devil's advocate for you, but there's
Yeah.
not just 1,000 women, right? So it's not that it's that big a risk, but if there are 150 million women and 100, a million women were to take it, you're now looking at, if people took it forever and you stay on it, you do increase your risk, and you're talking about 500,000 additional cancers. I think it's very important to know. It's not, again, I'm not saying that the risk is so big, but the one thing we do know with the drop in the use of Prempro, which was the largest, Wyeth had the leading drug that was prescribed, everywhere, and they way over touted the benefits and didn't talk about what the screenings were. That was the only time when that big drop over that period of time, there was a drop in the number of cancers that were caused. So I don't think we're talking about whether or not there is some risk. There is definitely some risk, but I think that there are ways in which you can mitigate that risk, and you can also take other things that don't really cause as much risk. So I think it's not that it's a big risk for any one person, but if you happen to be someone that's one of the nice things about knowing what your risk is. If you're in a high risk group, then you can think about taking things that have lower risk, like basidoxifene or something like that. That there are,
and the
that
risk needs to be put into perspective too.
Yeah.
And that even if you accept the risk from that study, which is not the formulations that we use, always going to remind the audience that we did use a synthetic progestin. And these days, when we can avoid using a progesterone or progestin, we do, as Dr. Esterman said, if you don't have a uterus, you take estrogen alone. And we don't have the same high quality randomized controlled studies of the size of the WHI to compare the different formulations. We wish we did. We wish, Dr. Esterman and I, we wish we had a study that looked at progesterone. And I don't have slides on this, but there has been other studies, not as large, that have looked at progesterone versus the synthetic progestin, and it seems to be less
Right.
of
So
a risk, less negative.
At the Rise Up meeting, so
Yeah, but we just don't have the same data. And then we're lucky.
DSP, for example, is probably much lower risk. But again, it would be so great to have the data.
We need the data. So we need a study like Wisdom for this. And then basidoxifene, which we can talk about, which is another, a substitute basically for the progestin. So if you're giving someone an estrogen, you have to protect the uterus if they have it. And so the brand name Duavie is a combination of an estrogen, of actually conjugated equine estrogen with basidoxifene, which acts like a SERM, a selective estrogen receptor modulator. So it blocks and degrades, right? Dr. Esterman degrades the estrogen receptor in breast tissue as well as in the uterine lining. So it's very safe on the uterus. It appears incredibly safe. There's excellent data on the safety of it in the breast. And I like to point out that this is an FDA-approved hormone therapy option. So particularly for my women who are concerned about breast cancer risk and menopause, they have dense breasts, they have a strong family history, it can be a very nice option to discuss with your doctor. But it's interesting. I still hear from a lot of doctors, OBGYNs, oncologists that they've never heard of Duavie. I'm like, which is crazy because it's such an important MHT option. So something to
Duavie. I mean, so basidoxifene is perhaps one of the most potent inhibitors of estrogen signaling. So it's in the family of tamoxifen, right? So it's a what we call selective estrogen receptor or modifier, but it has a number of properties that act not only to block the receptor, but to degrade the receptor. So very potent. But like the reason why these are part of this group they call selective estrogen receptor modifiers is because they can act as estrogen-like in some situations and anti-estrogen in others. So it's absolutely anti-estrogen in the uterus. So unlike tamoxifen, which is anti-estrogen in the breast, this is also anti-estrogen in the uterus, which is really great. I mean, it would actually, someone should make Duvet with an estrogen patch. They should have vasodoxine with an estrogen patch. That should be really
We would like that. And what's interesting is what we see in clinical practice is that women on Duvet, we don't see the breast tenderness. So if I have a woman who we've used an estradiol patch and progesterone, which there are benefits to that too, depending on certain symptom management. And the downside of Duvet is that it's a one size fits all dosing. So I can't up the estrogen dose. I can't lower the estrogen dose. It comes in one size, right? And so sometimes it's not the right option. But when women have persistent irregular spotting and bleeding that we've tried lots of things with, and they're on another hormone therapy, or they have persistent breast tenderness, you switch them to Duvet, they have none of either, which is really great.
And one of the things, if anyone is local, is under the age of 65, I think, and is having any hot flashes whatsoever, we have a study of Duvet where we're also trying to get the biomarkers to show that it reduces risk in the breast so that this could become an option for women who have had breast cancer and want some kind of hormone replacement.
That's phenomenal. How do people, so is that only local? How would people get involved?
It's at four centers. It's actually at the University of Kansas. So Carol Fabian is the national.
The Promise trial, right?
No, it's not. The Promise trial. That trial.
Oh, that's different. That's with DCIS. I'm sorry.
So that was that, and that's closed. But Carol Fabian has been doing work with this, and actually, it's open at Dana-Farber in Boston. So it's in the middle of the country at Kansas. It's I think Dr. Seawald has it open in Arizona, and then there's us at UCSF.
Amazing.
So. Yeah, so you can even just let us know at forum that you're interested at this forum, and we'll make sure to get you. Like I'm running the trial, I have it open here.
Oh, I love that.
You can call the breast care center, our breast care center, but it's so important to provide the data.
Yeah, because we can't move this conversation forward in anything unless we have data. And, women's health, I think everybody on here should know that, women's health is really underfunded, as you probably are aware. But the percentage that goes to things like menopause is even, sexual health, menopause. It's very sad how little is funded. So participating and sharing this information is really important.
One of the things I think is really important to talk about, and this happens to women with cancer and women without cancer, that women who have vaginal dryness or who have frequent urinary tract infections, actually one of the things that's so important is local estrogen. And in fact, we have done studies showing that S-string, which is a tiny little ring that, provides just enough estrogen locally to have the vaginal epithelium, lining, restore itself, because these cells, create mucus, which, prevents this. But and Vagifem is another one. Local estrogen is absolutely safe whether you've had a cancer or not. Any woman with cancer can have it. And it really, truly makes, especially someone who's had frequent urinary tract infections, it is something that everyone should ask about and make sure that their patients are okay in that regard. And it's also important for sexual health.
Yeah, it's something, Dr. Osman, that many women are really not informed about. Women don't even know what genitourinary syndrome of menopause. And I have this bit of a facetious slide here that says it kills, and I'll explain what I mean by that. but the lack of knowledge about that really just impacts women's lives in a lot more ways than it's the same thing where I think it's very dismissive when we just say menopause is just some hot flashes and vaginal dryness. Well, it's a lot more than hot flashes. We can talk about how menopause is a critical time in a woman's life where there's lots of physiologic changes that you need to be concerned about. Not that you need hormones for all of that, but you should understand that there's changes and things you can do for preventative health. And same with genitourinary syndrome. And this is something that doesn't require systemic hormone therapy to treat, right? And so, I'd say nearly 100% of women at some point will have some form of GSM. But many women don't know how to report it. They don't even think that that's what they have, or they think they just have to live with it. So I like to show this slide. So just everyone will bear with me and just take a look at this. And this shows the vaginal environment before menopause and after menopause. And whatever's happening there, I want you to remember it's happening on your vulva, on the labia, and in the bladder and the urethra. So on the one side, you have thick, moist tissue, good blood flow, elastic walls of the vagina, vaginal fluid, lubrication is secreted, but really focus on the blood flow. There's good blood flow to the vaginal walls, the vulva, the labia, and the clitoris, right? And collagen and all the good things, right? Once you go through menopause, and for some women, this doesn't hit them right away. It might take a number of years of loss of estrogen before they get symptoms. Other women, their receptors are probably really sensitive to the changes and just their genetics, and they may notice these symptoms a little bit sooner, even in perimenopause. And it's not just dryness, because if we tell women it's just dryness and don't inform them that the labia are regressing, the clitoris atrophies, you don't get the same blood flow, right? So when we tell women to just use a lubricant or some coconut oil, it's going to ease symptoms. It's not improving blood flow or thickening up the tissue or improving, natural lubrication or preventing urinary tract infections. And so this picture is important too, because on the right, it just shows all the urinary symptoms, like being woken up at night to pee, that's nocturia, or burning when you pee, or overactive bladder, where your bladder is, you have urgency, you feel like you have to go a lot, really frequent UTIs. It's all because that lining up into that urethra is not as strong, so it can't battle little bacteria trying to crawl up it, and it's just not as healthy. And I always want to just point out this picture of the vulva and the clitoris, because we ignore this in women. Ladies, 50% of men have erectile dysfunction by age 50. What is erectile dysfunction? It's loss of blood flow to the penis, right? They don't get as firm of erections. Well, the clitoris is a large structure. We only see a tip of it, but it lives underneath your vulva, and that fills with blood and gets aroused. And vaginal estrogen will help all of these structures not to atrophy. And the good news is we've got lots of professional statements on even breast cancer survivors being able to use low dose local vaginal estrogen. And I just wanted to show you guys a picture. I love E-string. That's this little ring there. It's so easy to put in. I've used it myself before. You pop it in there and it stays there for up to 3 months, and it slowly releases the estrogen locally. There's also little inserts, these little pink ones there. I really like those. That's Imvexi, because that comes in 2 strengths, a lower strength, like 4 micrograms, which if someone is maybe on an aromatase inhibitor for their breast cancer treatment, using the lower strength is probably the safest option, so that we're avoiding any potential for systemic absorption, although we've got very good data that we don't have that. Vagifem is a little pill. You could put that up inside. And then there's the vaginal cream. I will say my preference is when we're dealing with breast cancer survivors who are on aromatase inhibitors, we're going to try to use one of the little inserts and or the E-string, which is really stable and slow. Vaginal estrogen cream can also be used. We just want to, women can use a little bit more or a little bit less of the cream. So that would be the one where I would be, just give her very good instructions. But the benefit of the cream, I will say, is that we can use a little bit of it on the labia and on the clitoris, because sometimes when you're just treating up in the vagina, you don't get it to the area that it needs to be. And the one thing that's not on there that I really love, I don't think I have a picture of it, is there's a product called Intrarosa, which is vaginal DHEA. It's FDA approved for GSM. and it converts to estradiol and testosterone in the tissue. This is not testosterone for low libido where it gets systemically absorbed. It just is treating the vaginal and vulvar tissue. And women aren't informed of this, but your testosterone levels do slowly go down with age. And the vagina and the vulva in particular, the opening is very sensitive to that loss in androgens. And so if you fail on vaginal estrogen and you still have like pain with sex and or it's a little sensitive on the outside, the intrarosa can be a real game changer. And a lot of oncologists I find really like DHEA because it's not technically estrogen, it's DHEA, and it's being taken up just in the cells and converted to both the androgen and the estrogen. So working really great on those outside receptors. So those are some of my favorites. And I'm passionate about this because I see so many breast cancer survivors or other women who maybe can't take systemic hormones. Maybe they had a serious heart disease or they're an older woman and it's kind of too far past when they should initiate hormone therapy or whatever other reason why they're not. And they're suffering with GSM and they don't need to. So, speak up.
And I was also going to say whether you're on, and there are alternatives actually to, if hot flashes is the thing that's bothering you, if you've had cancer, a lot of times we'll give people gabapentin, but there's another medicine called Veoza. It's
here's my non-hormonal. Here, we got them.
Yeah, so the class of agent for the neurokinin antagonists, there's actually a new one that's coming out that may even have some breast cancer risk reduction that Carol Fabian is working on. But I have found these to be absolutely life-saving for people who really are suffering from, who have, recent diagnosis of breast cancer, terrible hot flashes, have been on hormone replacement for a long time. These are things that, I think that's new and it's a definite benefit. There's a
huge, and a lot of people don't get offered. So yeah, if you are suffering and you can't take systemic hormones or you choose not to, Fezolineant and the newer ones which will come, I also see that within literally a week or two, it can make a dramatic improvement when women are having really bad hot flashes, night sweats, and then it also helps their sleep. So I always want to point out that menopause has a strong impact on your sleep, not just if you have hot flashes, but certainly those hot flashes and night sweats make it worse.
And they're often an indication, they're the symptom.
And then there are others, there are SSRIs, SNRIs, gabapentin, and the one that's not on here is oxybutynin, which can also be helpful. It's a bladder medication that we use off label.
There's a question in the chat here that says, would appreciate it if you could also include what high-risk women who take prophylactic tamoxifen can do in menopause. And so, one of the problems with tamoxifen, and again, depends on the dose. If you're taking 20 milligrams of tamoxifen, the first thing you can do is drop that down to 5. That Andrea DeCenzi, who's in Italy, did a couple of really important studies showing that you can use a much lower dose, a quarter of the dose, we call it baby tam, and it seems to have the same impact if you have atypia or you have DCIS. It also, my colleague in Sweden, Per Hall, did a study where it was a double-blinded study. Again, people didn't know what dose they were on, and the investigators didn't know what dose they were on. That's what blinding means. So that really reduces bias. And they were using breast density as so if you get a drop in your breast density, that's one of the ways that that tamoxifen is working. That's actually one of the ways in which they figured out that tamoxifen would be a good prevention drug, is that in the women who had breast cancer way back when, who took tamoxifen when it was the mainstay of treatment, they noticed that they had a reduction in the rates of breast cancer on the other side, and that was particularly true if the breast density went down. So my colleague in Sweden said, okay, well, let's test a whole bunch of doses of tamoxifen and see which ones reduce breast density. And he did 1 milligrams, 2.5 milligrams, 5 milligrams, 10 milligrams, 15, and 20. And even 2.5 milligrams of tamoxifen reduced the breast density, but the symptom change, were so much different. People had so many fewer symptoms at the 5 milligram dose. It's very interesting in the big prevention study that was done, there were, 13,600 women. So really, close to 7,000 women in each arm. And about 10% to 15% of women quit because of hot flashes. But the same number quit in both arms because of so-called side effects. So, and there was a checklist of symptoms at the time. And so we didn't really pick up that tamoxifen really, really was bothering people, but you would hear that people were really bothered by it. And it was just hard to put our fingers on. But when you drop that dose down, there are still some people who really just have trouble because they get kind of foggy. But for the most part, if you take 5 milligrams of tamoxifen, you have far less. And so that's the first thing that I would do. And that was from Parisa. Was that, I don't know if that answers your question, but I think another thing for us to think about is, especially if you've got hot flashes, we can put you on the Duvet trial.
That would be fantastic. And you can take some of these non-hormonals with tamoxifen. We don't prescribe some of the SSRIs because they would lower the effectiveness of the tamoxifen. But I too have found that women on a reduced dose do really well. And we have to balance everything, right? Individualize it for you. And the same thing goes with active breast cancer treatment. We know the gold standard is full dose tamoxifen, of course, if that's what you're being prescribed. But if you are really suffering with your adjuvant endocrine therapy, you have to talk to your oncologist about changing aromatase inhibitor or changing it to tamoxifen or lowering the dose or a drug holiday or trying these non-hormonals. And yes, you can use vaginal estrogen with all of these things. So yeah, speak up because there's lots of ways to individualize it.
Yeah, so I would say to Parisa or Susie, if you the Duvet trial that we have open at UCSF is open, and that's one of the things we can do if your breast density goes down and you really takes care. I mean, I don't know about you, Corinne, but I have not really seen anyone go on Duvet and not have their symptoms resolve.
Oh, I have.
I mean, very rarely.
Yeah, I mean, I think it works great. But I also think we have to remind everybody that, menopause isn't just hot flashes and night sweats. Some people have really bad insomnia that is not just from your hot flashes and night sweats. We have to be concerned about osteoporosis. I think
That's a good thing about basidoxavine. It absolutely.
Joint pain. We have a lot of things. So I think it's always important. Like, we want to lower your breast cancer risk, but we also want to at the same time make sure we're taking care
I
of.
think one of the reasons I like basidoxavine is it promotes bone density and it doesn't cause joint ache. So that's
Duvet. I think I'm
Duvet.
excited about it and excited about that class of medications and tailoring more modern, menopausal hormone therapy options. We're desperate for data. Do we want to go through some of the questions here?
So I'm looking at Annabelle's. Okay, so first, Lauren Johnson was concerned about brain fog and mood swings. That can, again, a lot of these go away when you take a much lower dose of tamoxifen, but not always.
And it depends on where you are. If you're on tamoxifen and you're perimenopausal, a lot of it may not be certainly lowering the dose, but some of the symptoms are not from tamoxifen. They're that you're
menopause.
Or your menopause, which does cause mood swings, particularly perimenopause has a lot of, mood changes. We know it. There's direct impacts on neurotransmitters in your brain when you go through the perimenopause transition. And if you have a predisposition for anxiety or postpartum depression or major depressive disorder in the past, or you had well-controlled depression in the past, and now suddenly nothing seems to be working and your anxiety's through the roof, we always want to obviously look at other things, but not forget that this major hormonal change that's happening to you is probably exacerbating it. And so, work with your doctor to, address that. But so it's not always just the tamoxifen side effects.
I think there's a question in the chat about high dose estrogen, which again was used long time ago.
Oh,
But it does come with its own side effects, and there are new things that are being developed that we hope will be better.
oh
So
yeah. That's
Lindsay Irving has a good question here about and duvets. No, it's not just for women with a uterus. So
no, if you don't have a
and
uterus,
I'm strongly, anyone who's under 65 and is interested in the duvet study, you have to have
Yeah.
stopped having your periods. And that's like if you haven't had a period in 6 months and you're not 65 and you've got any kind of hot flash at all, you would be eligible for the duvet study. And you just let us know. Just let us, you can let us know here, and I'll get one of our coordinators to reach out to you. Now, somebody wanted to talk about options for triple negative breast cancer survivors. And that is, doesn't seem really quite that sensible to make people stop all hormones. I think that no matter what I would do if you have triple negative breast cancer, I don't think that, especially if you've gone through premature menopause, I would certainly recommend, doing, again, what you can do is you start with the minimum amount you need to restore to prevent symptoms. But those are things that talking with people who are knowledgeable, right, who are used to doing that and are specializing in that, I think is really important. Don't you, Corinne?
yeah, what I would jump in to say about triple negative breast cancer is, listen, we know that there's a period of time where for triple negative breast cancer, there's a more predictable timing of recurrence. And we know with all breast cancers, recurrence can happen at any time. But we know that the majority of triple negative breast cancer patients, if they're going to have recurrence, it's going to be in the first 2 to 5 years, peaking around, I think,
Well, yeah. So your risk is largely done by 5 years.
yeah. So
Not so much the slow growing hormone positive breast cancers, unfortunately.
no, but when we're talking about, yeah, triple negative breast cancer,
it's 5 years.
yeah, and so because we know that young women are, more likely to have triple negative breast cancer, I see a lot of young women. I have friends in the Young Survival Coalition, which I'm really active in, who survived their triple negative breast cancer. They were diagnosed in their late 20s or say early 30s. And then they went on, right? Their periods came back after chemo. They went on to have a number of years of, normal ovulatory function, super high estrogen levels, right? Because when you are getting your periods, your estrogen levels are surging up and down every month. And then for some of them, they either went through natural menopause or some of them carried the BRCA1 or 2 gene, and they have then elective oophorectomy. They get their ovaries, out early before age 40. And then suddenly they're like pariahs and no one will talk about replacing their hormones, and they have premature surgical menopause, or they have natural menopause and they're really suffering. It makes no logical sense to not have shared decision-making discussion with those patients and start with the lower dose, as Dr. Escherman said, lower dose of an estrogen and a progesterone to meet your symptoms. And even small amounts, guys, even very small amounts are quite protective of bone loss as well. So it's treating your symptoms, will help with bone loss. And you can, of course, use vaginal estrogen. But there's a real fear-based knee-jerk reaction to breast cancer touched you in some part of your life. We can't have a discussion with you about hormone therapy, which that is evolving as women demand shared decision-making and individualization.
And I would in general, I would want to avoid any progestins and if you've had triple negative breast cancer, but plenty of options like Duvet and other things. You just not something that you need to think about. Now, the other thing someone asked about was, and this is our last questions because I know we're over time, is it says, but what about hormone replacement for someone who had DCIS, had a bilateral mastectomy and was BRCA2 and had a BSO? When someone's had a bilateral mastectomy and had their ovaries out, we routinely allow them to have hormone replacement therapy. Whatever amount of hormones they're getting is less than they were just having.
100%. I find it horrifying.
I don't understand that mentality. I mean,
I prescribe.
You gotta have something for getting a bilateral mastectomy.
Yes. So I routinely prescribe to women who have had a bilateral mastectomy DCIS. listen, in life, there's nothing called zero risk or zero chance of recurrence. But if you've had a bilateral mastectomy for DCIS without invasion, you've not been told to take tamoxifen because your breasts are gone, your breast tissue is gone. Now, theoretically, could there be one cell left over? Yes, theoretically, there could be. But, you've lost your ovaries or you've gone through natural menopause. There's no reason why you could not be given back hormone therapy. And in fact, I think it's cruel and it's unreasonable. And again, it's a knee-jerk response versus a thoughtful response. And I always flip the script. I say, when you have DCIS with a bilateral mastectomy at, say, 43, you still are getting your periods, right? Like, unless you've had your ovaries removed. So you might go and have 5, 6, 7, 10 years more of periods. Then suddenly at menopause, because of your distant DCIS history, you can't get your hormones. If you're having a little bit of low dose hormones for your symptoms, suddenly that's not okay. See, it just doesn't make sense. And that's because there's just a lot of fear around this. And OBGYNs are not educated in menopause. If you think breast surgeons or medical oncologists are, they're not. So we've got a huge care vacuum, huge.
Well, yeah. So I there's so many questions, and we don't have time to answer all of them, but this is obviously something that, and our time is up, and obviously, there are, and Annabelle, I'm sending you a message in the chat. So I think that again, if you can find someone who is educated, the other thing that we are working on is I put in the chat also for people, the diagnosis of DCIS, we actually have an active surveillance study for women with DCIS, trying different endocrine interventions to try and see if we can reduce risk and control symptoms. And I would say also that we have a conference now called Rise Up for Breast Cancer. Our next one is in February of 2026, but we're going to be focusing in a lot of these questions. This is why can't we make better interventions for cycle control, birth control, postmenopausal hormone replacement, IVF, and, postpartum weaning to relieve symptoms, improve overall health, and reduce breast cancer risk. So what we want is, people to use their imagination to help us make the future better for women. Corinne,
shout out, Menopause and Cancer is an incredible nonprofit out of the UK. If you are a cancer survivor of any type, or you have a cancer survivor in your life, she's got incredible resources, incredible experts, and really does a wonderful job of showing you all of your options and how important lifestyle, nutrition, non-hormonal options, but also how to have the more difficult conversations with your breast cancer team about things like vaginal estrogen and systemic hormone options, if it is something for you to consider. So if you're looking for a place to delve into that, please check that out. And a shout out to the Young Survival Coalition for any of my young survivors out there. They were a lifeline for me. Personally, I'm an active volunteer and work with them a lot. And on my social media page, I do a lot of education on all of this. I have a course for doctors, one for women, and just are constantly doing contact. So if you need some resources, check me out there.
Awesome. Thank you so much. If you don't mind, I'm going to share one last slide just to wrap up. But while I'm doing that, thank you so much for joining us for the great conversation. I know there are tons of questions that didn't get answered, but tons of questions that did. There are also some requests for some sort of overview cheat sheets on which medications are which and for what and things like that. So we'll work on getting something out to the group as well. And as Dr. Menn mentioned, there are other resources that we can point you to as well. But big thank you so much for joining us. And I think we'll have to have you back to continue the conversation and keep the conversation going. Just quickly, thank you to everyone for joining. So we do have our next community forum in April. It's on April 28th, and it's breast cancer during pregnancy and postpartum with Dr. Ginger Borges. And so we'd love for you to join us next month as well. Again, your registration link is good for all future forums. So thank you for joining us. There's also an evaluation link that will be popping up in the chat. We'd love to hear from you. And if you have questions that didn't get answered, feel free to add those in and we can make sure that we try and address those questions perhaps in a future forum.
And Corinne, thank you so much for sharing your story and spending the time with us and for all the good work that you do. And we'll see you soon.
Thank you, Dr. Esterman. You're so inspiring, and I really am honored to have been here to speak to all of you guys. So thank you.
All right. Thanks so much, everyone. Have a great evening.
Everyone.